Welcome to the MarylandEMS Protocols Base Station Updates for 2025. First, I would like to thank you for taking a few minutes of your time to learn about our protocol updates for 2025. The hospital base station is a critical component of our EMS system as it provides online or real-time medical consultation for our EMS clinicians. It's not always possible or practical to write a protocol to cover every possible pre-hospital situation. As a base station, you are providing guidance for EMS clinicians in these tough cases. Before we dive into the new protocols, I'll cover a few topics that frequently arise during base station consults. These items include refusals, destination determination, hospital crowding, and medications. First, refusals. As you know, patient refusals are one of the highest risk encounters in EMS. For patients who lack medical decision-making capacity, EMS clinicians are advised to transport under implied or emergency consent guidelines. However, EMS clinicians will generally consult when the patient has unstable vital signs, or a serious chief complaint, or an exam finding, and yet still have medical decision-making capacity. To be clear, the purpose of this consult is not for the physician to approve a refusal. Rather, the physician should echo the EMS clinician's concerns, if possible, in an effort to persuade the patient to accept treatment and transport if appropriate. Destination determination. The goal of the MarylandEMS system is to deliver the right patient to the right destination in the right amount of time. Inherent to this process, patients can be under or over triaged. It's inevitable. However, when taking a consult for destination determination, please account for a few factors. First, the patient's anticipated medical needs. Secondly, whether the patient was admitted recently to your facility. And third, whether the patient is sufficiently stable to tolerate longer transport distances. Please keep in mind that EMS has the most accurate view of their geographic location, and second-guessing which hospital is closest to the incident is generally not going to be helpful. If the hospital base stations disagree during a dual consultation, please aim to quickly resolve this. Avoid prolonged discussion between hospitals. If agreement cannot be reached between base stations, we should generally defer to the guidance of the higher level center. There is always opportunity to assess the destination decision after the patient has been stabilized. Hospital crowding. Hospital crowding continues to be a significant issue statewide. Soon, a new emergency department advisory system will be launched that uses ED census data that is supplied by the hospitals on at least a daily basis. The system will have a dashboard that shows a measurement scale from 1 through 4 that gives us a more dependable assessment of how busy a hospital is. In addition, it will display the number of units en route to and those already arrived at the facility. The dashboard is intended to inform EMS clinicians so that they may counsel their patients on the most appropriate facility for their care. We recognize that all hospitals continue to experience heavy volumes in proportion to their size, so please realize that this may not ultimately change the destination for the patient. More information regarding the ED advisory system is coming soon. Medications. The Maryland Medical Protocols for EMS are meant to reduce the need for unnecessary or routine calls just to get permission to give medications. Typically, EMS clinicians will consult for medications when they've exceeded their standing orders, or if there is a question about dosing, or if there are concerns for potential adverse effects. For example, EMS clinicians are required to consult prior to giving ketamine unless there is an immediate and imminent risk of harm to the patient or others. We would like them to closely weigh the risk and benefit of giving this medication. We would ask you to please assist EMS with weighing that risk versus benefit of ketamine versus other medications, potentially such as midazolam or droperidol. For review purposes, a full list of medications in the ALS and BLS formularies follows here. Here is a list of the 8 BLS medications. Most of these medications may have a first or second dose given without consult. A notable exception is activated charcoal, which always requires consultation due to the need to assess the patient's aspiration risk prior to administration. The ALS formulary is extensive. I have included the new medications for 2025 in red text here. Meds that are marked shortage only are available to EMS clinicians only when there is a documented regional or national shortage of the primary ALS medication. For example, in the case of a regional midazolam shortage, diazepam may be used temporarily. Please note that there are additional medications that are not on this list, such as buprenorphine or RSI medications that are used only by certain paramedics who have had additional training. Please take this opportunity to pause and scroll through the video and familiarize yourself with the medications available to Maryland's EMS clinicians. Now, let's take a look at the new protocols for this year. As mentioned in prior years, there are a few general reminders regarding the Maryland EMS protocols. First, Maryland's EMS protocols are updated on an annual basis. The additions and changes for each year go live on July the 1st. Second, this update focuses only on the additions and changes to statewide treatment protocols. We have several optional supplemental and pilot protocols that jurisdictions may take on. The jurisdictions and their medical directors provide additional training, equipment, and ensure thorough review and medical oversight. We will not cover these during the current presentation. However, EMS agencies and base stations should stay in close communication so that they know if a given county is participating in any optional or pilot protocols, particularly those that may require medical consultation. The entire protocol document is available on the MIMS website. I've included the hyperlink at the bottom of this slide. There are several significant new EMS protocols this year. They include the following: a protocol for the treatment of alcohol withdrawal syndrome, the addition of cefazolin, an IV antibiotic for treatment of open fractures, the addition of the distal femur site for intraosseous access in pediatric patients who are less than 13 years of age, and a comprehensive protocol that addresses hypertensive disorders of pregnancy, including gestational hypertension, preeclampsia, and eclampsia. Let's take a closer look at each. First, alcohol withdrawal. For patients with psychomotor agitation and suspected alcohol withdrawal, EMS clinicians will calculate a brief alcohol withdrawal score, or BAWS. The BAWS is similar to the CWAS scale that is used in many hospitals. It is calculated based upon the presence of tremor, diaphoresis, agitation, confusion, or hallucinations. Each area is scored 0 to 3. A total score of less than 3 indicates mild withdrawal. In these cases, EMS will administer antiemetics such as ondansetron or droperidol as needed for these patients. However, a total score of 3 or greater indicates moderate to severe alcohol withdrawal. In these cases, ALS clinicians may administer up to 3 doses of midazolam in 2 to 2.5 milligram increments. Consultation is required after the 3rd dose. Notably, if there's no IV access, clinicians will administer a single dose of 5 milligrams of midazolam by the intranasal or intramuscular route. Consultation is required for additional intranasal or intramuscular doses after the 1st dose. We expect that EMS clinicians will frequently reevaluate their patients' vitals and symptoms. Protocol will allow patients to receive appropriate and earlier treatment for their alcohol withdrawal symptoms. Next is cefazolin, which is also known by the brand name Ancef. For patients with suspected open fractures, extremity amputations or partial amputations, or mangled and degloved extremities, EMS will now be able to administer a dose of cefazolin, which is commonly known by its brand name Ancef. Early administration of antibiotics reduces the subsequent rate of infection and non-union. Although emergency medicine guidelines emphasize the need for early antibiotics for patients with open fractures, it is common that antibiotic administration is forgotten until later in the ED stay. A case review from the National Trauma Data Bank revealed that only 48% of patients received antibiotics within 1 hour of arrival to the ED. The EMS protocol emphasizes that patients should receive antibiotics only after stabilization of life threats. In other words, cefazolin should not impede resuscitation or timely transport. Recommended dosing is as follows. For patients 13 years of age and older, the dose will be 2 grams. For patients ages 5 through 12 years, the dose is 1 gram. And for patients 1 through 4 years of age, the dose is 500 milligrams. For patients who are less than 1 year of age, a medical consult is required for dosing recommendations. All doses should be given by IV or IO in 100 mL of normal saline, lactated ringers, or D5W over 10 minutes. Out of an abundance of caution, if the patient reports an allergy to any cephalosporin or penicillin, EMS will not administer cefazolin. Distal femur IO site for pediatric patients less than 13 years of age. The distal femur has been added as an IO site for pediatric patients under 13 years of age. The chart in Protocol 12.20, intraosseous infusion, shows the preferred and backup sites for IO access by age. In children less than 13 years of age, the preferred site is the proximal tibia. However, if this site is unavailable, backup sites include, in order from best to least preferred, the distal femur, followed by the distal tibia, and finally the proximal humerus, using a 15-gauge IO for this age group. In neonates, those patients less than 3 kilograms, the preferred site is the proximal tibia, followed by the distal femur. In this age group, an 18-gauge IO needle should be used. Just to recap, an 18-gauge IO needle should be used for neonates less than 3 kilograms, and a 15-gauge IO should be used for all other age groups. Please note that there are no changes to the permitted IO sites for adults this year, and the preferred site for adults remains the proximal humerus. If this site is unavailable, backup sites include the proximal tibia and then the distal tibia. Hypertensive disorders of pregnancy. Hypertensive disorders of pregnancy, or HDP, are a leading cause of pregnancy-related death and severe complications. The incidence of HDP is on the rise. A CDC study documented an increase in the proportion of pregnancies affected from 13% in 2017 to nearly 16% in 2019. In Maryland, EMS has called for OB patients with severe hypertension, systolic blood pressures greater than or equal to 160, or diastolic blood pressures greater than or equal to 110, several hundred times per year. The red areas on this map indicate 50 or more EMS calls over the past 3 years. Historically, the identification and treatment of elevated blood pressures in pregnant patients has not been a primary focus for EMS. The 2025 protocols recognize the critical role that EMS clinicians play in the identification and early treatment of gestational hypertension, preeclampsia, and eclampsia. For patients who are greater than 20 weeks gestation or up to 6 weeks postpartum, the protocol will advise EMS clinicians to check blood pressures at least 2 times and at least 15 minutes apart. If the patient meets moderate or severe criteria, we will initiate treatment with magnesium, labetalol, or both. Moderate criteria patients are defined as those with blood pressures between 140 and 159 systolic or 90 to 109 diastolic, who also have either a known history or signs of severe preeclampsia. For these patients, we will initiate 4 grams of magnesium sulfate over 10 minutes. Severe criteria patients are those with a systolic blood pressure greater than or equal to 160 or diastolic blood pressure greater than or equal to 110, with or without signs of preeclampsia. These patients should receive magnesium sulfate 4 grams IV or IO over 10 minutes and labetalol 20 milligrams IV or IO over 2 minutes. A second dose of labetalol 40 milligrams IV or IO over 2 minutes may be given if the blood pressure remains elevated. ALS clinicians must consult for third or subsequent doses of labetalol. The goal blood pressure range is 120 to 160 over 80 to 110. Finally, for pregnant patients over 20 weeks presenting with seizures or suspected eclampsia, ALS clinicians will administer magnesium sulfate 4 grams IV or IO over 10 minutes. If the seizures persist, midazolam 5 milligrams IV, IM, IN, or IO can be given. Additional doses of midazolam may be given with consultation for seizures that persist. That completes the new protocols for 2025. Now I will discuss a few of the revised protocols, which include dexamethasone, hypothermia, sepsis, submersion injury, both with and without cardiac arrest for adults only, minor revisions to the protocols, and protocols that have been removed. First, let me cover dexamethasone. For dexamethasone, the maximum dose changes from 10 to 15 milligrams for all patients. EMS may administer dexamethasone by the IV, IM, IO, or PO routes depending upon patient severity. An IO should only be used when it has been placed to deliver other life-saving medications. An IO should not be used for the sole purpose of giving dexamethasone. Pediatric dosing remains 0.5 milligrams per kilogram, but the max dose changes from 10 to 15 milligrams. Next on the list is hypothermia. EMS will transport patients with severe hypothermia, for example, those who are hypotensive or bradycardic, and patients in cardiac arrest due to hypothermia, to an eCPR-capable center with just a couple of caveats. Injuries that are incompatible with life. When an eCPR-capable center is greater than 30 minutes away, EMS will transport to the closest facility. For patients who are less than 18 years of age, EMS will transport to pediatric eCPR-capable facilities if they're within 30 minutes. Next, for sepsis. For a non-fluid sensitive patient, ALS clinicians will administer 2 liters of lactated ringers wide open. This is unchanged. If the patient remains hypotensive, they may give additional IV fluid up to 30 mL per kilo. However, for fluid-sensitive patients, which include patients who have congestive heart failure, end-stage renal disease, or pulmonary edema, ALS clinicians will infuse 250 milliliters at a time to a max of 500 milliliters of LR prior to consultation. We don't want to volume overload these patients. Next, for the epinephrine infusion, for significant hypotension, defined as a systolic less than 70 or MAP less than 50, and altered mental status, ALS clinicians will now initiate epinephrine infusions concurrently with the lactated ringers as noted above. For fluid-sensitive patients, ALS clinicians will initiate an epi infusion if the patient remains hypotensive after that initial 500 ml LR bolus. Submersion injury, which was previously referred to as near drowning. We've undertaken a comprehensive review of the submersion protocols. Submersion was previously referred to as near drowning. In addition to updating the terminology, we have also incorporated evidence-based recommendations for patients with submersion injury, both with and without cardiac arrest. First, let's take a look at submersion injury without cardiac arrest. This protocol applies to both adults and children. Submersion injury may be classified into mild, moderate, or severe criteria as follows. Mild patients should receive oxygen and treatment with NEBS for bronchospasm. Moderate patients should be given high-flow oxygen and assisted with ventilations via BVM, CPAP for patients 13 years of age or older, and/or intubation, as well as receiving treatment for their bronchospasm. Severe patients will require rescue breathing or CPAP for patients who are still conscious. We advise EMS to consider early intubation or an extraglottic airway. If the systolic blood pressure is less than 90, they will initiate lactated ringers fluid bolus and epinephrine infusion. Moderate or severe submersions should be transported to an eCPR-capable hospital or a trauma center, as submersion injury constitutes a lung injury if the patient condition allows. Now, let's shift attention to submersion injury with cardiac arrest. In this revision, we have focused attention on water temperature and time of submersion when considering continued CPR versus the termination of resuscitative efforts. Importantly, this protocol applies only to adults, those patients who are 18 years of age or older. The first area of the protocol to discuss are patients who experience submersion injury in warm water with submersion time 30 minutes or less. These patients should receive full resuscitation attempts, early intubation with consideration for increasing PEEP or positive index expiratory pressure as needed, and placement of an OG or NG tube. ALS clinicians may terminate resuscitative efforts per the medical termination of resuscitation algorithm if the patient has received at least 15 2-minute cycles of HP-CPR and they're in asystole, or VFib, VTAC, or PEA with end-tidal CO2 of less than 15 millimeters of mercury. Next is warm water with submersion time 30 minutes or more. For these patients, ALS clinicians should place the patient on a cardiac monitor. If the patient is already in asystole, they may pronounce death. However, for rhythms other than asystole, they should initiate resuscitation. ALS clinicians may terminate resuscitative efforts per the medical tour if the patient has received at least 15 2-minute cycles of high-performance CPR and they're in asystole, or if they're in VFib, VTAC, or PEA with end-tidal CO2 values of less than 15 millimeters of mercury. Now, let's review cold water submersion. For patients who are in cold water with submersion time 90 minutes or less, clinicians should initiate resuscitation and transport to an eCPR-capable center. Helicopter transport can be considered if the drive time is 45 minutes or greater than the closest facility. EMS clinicians should obtain early medical consult for hypothermic cardiac arrest patients, particularly for guidance on drug and defibrillation intervals. For patients who are in cold water with a submersion time greater than 90 minutes, ALS clinicians should again place the patient on the cardiac monitor. If the patient is in asystole, they may pronounce death. However, for rhythms other than asystole, they'll initiate resuscitation and transport to an eCPR-capable center. Helicopter transport again can be considered if the drive time is 45 minutes or greater than the time it takes to get to the closest facility. Obtain early medical consultation for hypothermic cardiac arrest patients, particularly for drug and defibrillation intervals. Lastly, if return of spontaneous circulation is obtained, EMS clinicians will refer to the ROSC protocol and transport. Preferred destination will be eCPR-capable centers. If the drive time is 45 minutes or greater, EMS clinicians will consider helicopter transport. For unknown submersion times, EMS clinicians will resuscitate and refer to the adult termination of resuscitation algorithm for medical arrests. If the patient does not meet adult medical tour criteria, they will continue resuscitation and transport. This is one last reminder that this protocol update is just for adult patients, and please note that pediatric patients who have submersion injury with cardiac arrest will have resuscitation attempted and be transported regardless of the water temperature or submersion time. Obvious exceptions to this protocol include patients who have injuries that are clearly incompatible with life. Now, I will address a few minor revisions to the protocol for this year. For droperidol, we've added the intramuscular route for nausea. For emerging infectious diseases, we've updated terminology throughout the algorithm to broaden it. For calcium chloride, all dosing intervals for simplicity are now 3 to 5 minutes throughout the protocol. For sodium bicarbonate, we've added this medication to the IV infusion pump protocol. And for wilderness EMS, we've added a few medications, including doxycycline and hypertonic saline, which does require consultation. Importantly, the hypertonic saline would only be used in witnessed exercise-induced hyponatremia. Freestanding ED protocols have been consolidated into one. And for pediatrics, for pediatric narrow complex tachycardia, we've added a consult for cardioversion. These are very rare instances, and oftentimes the patient may be able to be managed without cardioversion. The following protocols have been moved from an optional status to standard statewide protocol. The first is naloxone leave-behind. For some quick background, in Maryland, about 30% of patients who receive treatment by EMS for an opioid overdose are not ultimately transported to an ED. Though an optional protocol was released many years ago, most EMS jurisdictions have been providing that dose of naloxone for patients who are not transported to a hospital after treatment for an opioid overdose. In other words, they're leaving a dose behind after the patient's been treated. These naloxone kits have been provided by the health department for EMS to leave behind with patients or their family members. And often, EMS clinicians will also provide referrals to treatment resources. Effective July the 1st, naloxone leave-behind will become part of the standard statewide EMS protocols. You may find it interesting to know that, in addition to naloxone leave-behind, a few counties have also started to administer buprenorphine through their mobile integrated health teams. Next, videolaryngoscopy will also become a standard statewide protocol. This change will occur effective July 1 of 2026. Recent data indicates improved odds of first-pass success and overall intubation success with videolaryngoscopy. Therefore, we have moved videolaryngoscopy capability to the standard statewide EMS treatment protocols. Importantly, EMS clinicians will still have access to direct or conventional laryngoscopy. This move will go into effect July 1 of 2026, which will allow EMS services more time to purchase equipment. And lastly, we've removed two protocols for 2025, the vascular Doppler optional supplemental protocol and the COVID-19 antibody administration for MIH protocol. That's the conclusion of the updates to the 2025 Maryland Medical Protocols for EMS. If you had not already heard, we launched a mobile EMS app that stays current with protocol updates. This gives us another way to make EMS protocols quickly accessible, and it's a great way to stay up to date. The app is available free of charge and available for both Apple iOS and Android platforms. Please check it out by using the QR code. In closing, I'm grateful for your continued support of Maryland's EMS system. Hospital base stations serve a critical role in the provision of online or real-time medical consultation for Maryland's EMS clinicians. Thank you again for taking the time to learn about our protocol updates for 2025.